Hi Arunal, I'm Peta-Gay Ricketts, first year rheumatology fellow at the University of Pittsburgh Medical Center here at RWCS 2022. Today I will share a case titled A Tale of Two Vasculopathies. So we have a 68-year-old African-American male with a recent diagnosis of lupus and stroke presents with altered mental status. For 1 week, he was unable to perform his activities of daily living, and family noted he was confused. On exam, he was found to have hypertensive urgency, but no focal neurologic deficits. He was alert to person only, apathetic, confused, and unable to follow commands. So rheumatology was consulted, given concern for neuropsychiatric lupus. In terms of diagnostics, his MRI brain showed subacute infarcts related to his recent stroke, but no hyperintense focal lesions. He was found to have elevated inflammatory markers, high titer double-stranded DNA antibodies, hypocomplementemia, suggestive of high lupus disease activity. He also had acute kidney injury. We performed a renal biopsy that showed class 3 lupus nephritis. His CSF studies, antiphospholipid antibodies, and an extensive infectious workup was largely unrevealing. So at this point, our leading diagnosis was neuropsychiatric lupus. He was treated with high-dose steroids, and his confusion state resolved. On hospital day 11, however, he developed autoimmune hemolytic, which was unresponsive to IV steroids. On day 17, he was treated with rituximab. On day 18, he developed a severe headache described as a thunderclap headache. CT angiography was performed, which revealed stenosis in the M2 segment of the left bilateral middle cerebral arteries, as demonstrated here, raising concern for secondary CNS vasculitis. We treated this gentleman with IV steroids and continued rituximab for his autoimmune hemolytic anemia. He was discharged with oral prednisone, mycophenolate mofetil, and Plaquenil. 5 weeks later, he was presented with angioedema secondary to lisinopril use. At that point, CT angiography was performed, which actually showed the M2 segment of the left middle cerebral artery was patent compared to prior studies. So this raises an important question in our case. Did our patient have reversible cerebral vasoconstriction syndrome or secondary CNS vasculitis? This case illustrates CNS vasculopathy in lupus, which is a rare occurrence. Thank you.